And I welcome you all to the Hospital Systems Addiction Care Community Practice meeting for June. Today we're having a roundtable discussion, a smaller roundtable than I thought it would be, about peer recovery support systems and making this work for New Hampshire hospitals. We can move to the next slide. The objective here is that those of us here come away having learned something about peer recovery support systems and how, not so much how they work, but how they are successful and the challenges, and especially for people in leadership, how to take that input and make them better. And next slide. This community of practice is dedicated to the promotion of enhanced care for people with substance use disorder, their engagement, treatment, coordination of services, and ultimately to improve the outcomes of our public health. We are funded by the Bureau of Drug and Alcohol Services. We are happily partnered with Growth Partners, and I am Dan Andrews of the Foundation for Healthy Communities. With that, we'll move to the next slide, and my goal is to have Carol Furlong talking while it is still 1:05, and then we'll have presentations, first from Carol, and later on from Concord Hospital, Lakes Region, and Dartmouth. We have an excellent group today. We have folks who are leaders, and we have folks who are peer recovery specialists who are also leaders in this new and groundbreaking field. We have a nice mix. So with no further ado, I would like to turn this over to Carol Furlong, who is the, I'm going to say, Director of Strategic Planning. I am working without my notes. Hang on here. Strategic Planning Consultant. That's what you do after you retire from being the Substance Use Services Director. Carol, welcome. And the floor is yours. And you are muted, I think.
There we go. So my job as the strategic consultant is to guide the hospital through whatever efforts we need to make to encourage recovery throughout the greater Manchester area, and to make sure that we have destigmatized all of our services throughout the hospital, along with other missions, but those are chiefly how I see my job. In our substance use department, we have several different programs. One is a partial hospitalization program, and we have a peer support position within that program. We have a master's level clinician, licensed master's level clinician in our emergency room. We have the drug court program, and we utilize Revive Recovery and their peer support system for those participants. The drug court program also includes an intensive outpatient program, but we're very active with Revive. And in fact, Revive is so engaged with us that they come to our graduation and have a great deal of participation with us. And then the last program that we have is the Mom Grant. And that's for women who are pregnant and have an opioid addiction, or are postpartum and still needing care and coordination. We have a very active peer support person in that program. So in both the drug court program, in the partial hospitalization program, they are part of the clinical team. So they meet with people regularly. There may be times when they participate in group therapy, but they want to make sure that people are connected. They work very closely with the case manager. And more than anything, they just want to make that connection to talk about how difficult it may be and what the resources may be. We want to present them with someone with lived experience so that they are not just getting the perception that they're being lectured to by the medical staff. In our drug court program, as I said, Revive Recovery is incredibly involved with us. And it's worked out really well in that, as drug court systems work, sometimes participation in a peer support group is actually a sanction. So they've not done well in some of their instructions, and the judge will mandate that they attend peer supports. What works out really well is they're mandated to go, they have to be there, but they end up developing relationships and really seeing the value of it. And so then they are likely to expand their contacts. And many of them then go to Hope for Recovery and get very involved then. And then they find their own home groups. So it's been a successful process for us. In the drug court program, in the mom program, that's probably our most active peer support staff. They work very closely. They kind of are with them all the time. They coordinate throughout the greater Manchester area. They'll make sure that they are getting the services that they need. They will also visit them in the hospital and on the maternity unit just to make sure everything's going well. Challenges in working with peer support or providing peer support services, there really aren't any. The hardest one is finding people. We ask that people have 3 years of recovery, 3 to 5 years, but 3 is adequate at this point. And that's sometimes hard to find people with that amount who are interested in these positions. But the benefits far outweigh any possible challenges. We talk a lot about why do we offer peer support services, and it's to give that hope, to help them see that there is recovery, to support them through that. And we mostly talk about the impact on the patients or the clients, the participants in our program. What we don't talk about as often, and what really has been as great an impact at Elliot as anything else, is the impact on staff. In the emergency room, people tend to have compassion burnout. They see the same people over and over again, and they get tired of it. They get burnt. They get frustrated. But having someone there with lived experience who can talk about their experience and how frustrating it was for them sometimes, but more importantly, to talk about that one nurse, that one medical provider, and that one medical experience that they had that gave them that glimmer of hope. That makes all the difference to the staff. So much so that in our maternity unit, in which our peer support from the mom grant has a lot of contact, their whole culture has been changed. People don't talk differently. People talk differently. They're very much aware if someone makes a stigmatizing comment, and they don't mind correcting each other. They do it nicely and supportively, but that's just not acceptable behavior anymore. And it reached kind of the crescendo when they decided not only did they want to give out Narcan to moms who were being discharged, but they offer it to everybody. Every new mom is offered Narcan. And when they refuse and say, no, I don't need that, the response is, well, you may not, but I bet you know somebody who does. And so just have it available. And that's largely as a result of having a peer support person who can help them identify individuals with substance use issues as you and I, as our family members. They're just one other staff person. They're just one other person. They just tend to have different experiences and a different set of skills. Those are the benefits of it. And we just can't measure enough how well that's worked out. That's it.
This is the day to stay muted. I am unmuted now. Are there questions for Carol or anybody want to ask any follow-up? She still has a few minutes here.
I will ask a question. I'd like to know how you got started in bringing peers on board.
We started, the PHP was the first program really that we had, and we saw the impact of that. We then wanted to look at what other programs. It was so important. We wanted to start adding it to our other programs. And so in drug court, the funding was more limited. And we were approached by Revive Recovery and wanted to take full advantage of that. because one of our goals, again, with drug court is to make sure people become critical members of the community. And so this was a way to make that contact. It wasn't just allocated or contained within an Elliot program. This was a community contact. So that's why we went there. And then it just seemed understood that when we had the mom grant, especially, that we would include someone with lived experience. Who best to talk to them, to talk to our patients about what they've been through and what they've been able to achieve. And then, you know, we just never, to be honest, we never thought about the impact it would have on our medical staff. But these are different people since they've had these experiences. They see the world differently. And I don't just mean substance use world. They see the world differently because they're really able now to see people past the limits, the labels, the diagnoses, and see them as having a lot of shared experiences. So they're seeing, in the maternity unit, for example, they're seeing people who are giving birth who are just like you and I, but there is this other issue, this other medical issue, and that's been a great change too. One success just led to another.
Awesome. Thank you for all that energy. Any more questions for Carol?
I have one, Carol, and it's a little bit in the weeds, sort of. This is Pete Fifield.
Yeah.
So the Revive Recovery employees, but they're working in your hospital. Are they persons of interest? Like how does that? And this could be an offline question, but I'm really interested in the detail of how they're employed by the hospital.
Yeah, they're not employed by the hospital. We have a contract with them.
Got it.
Drug court does, but our clients go to Revive, go to their meetings, have their contacts. And because they establish those relationships, then the people from Revive work very closely with them. They're not a part of drug court. Contractually, they're not employees, but they're contracted with us to provide these services. And they become intertwined with the work we do.
Got it. So they're not like the Revive or peer specialists aren't actually in the ED.
No.
Okay. Got it. Got it.
Yeah, we have other staff that we have our mom grant person in the other positions.
Yep. Wonderful.
Yep.
Thank you.
Yeah, sure.
Anything else for Carol? Monica, I'm happy to turn the spotlight to you. This conversation follows up a conversation that I had in Monica's office a few weeks ago, and some of the excitement around talking with some folks who are doing peer recovery, and just so pleased to have you here and to represent that. And I'll turn the spotlight on you.
Well, good afternoon, everybody. Hi, Monica Edgar. I'm the Director of Substance Use Services for Concord Hospital in Concord. I'm going to give you a little bit of background. So in terms of our program, we're an outpatient program for substance use disorders, and we treat adults. We then also have been responsible since the conception of this department for the inpatient consultation. And that's what that's where our peer support is in. So that service line, I'm going to give you a little more history about it. So the inpatient consultation, initially, that's all the work that we did in terms of if that came into the department. That's what was our big referral source. This goes back to 1996, believe it or not. Over time, I've seen that change because obviously payers have changed, the Medicaid in 2015. So our referral sources come from other agencies. But that's how we kind of got started. This department first was, majority of it was doing inpatient consultation. As we've grown to more of an outpatient department, this inpatient consultation service became, I would say it has struggled in terms of for the staffing. It became something that we had to go and do after, in between seeing the patients in the IOP or individual patients after the other outpatient services were being performed. To more recently, I kind of changed that under this contract to having a different model of care, specifically having somebody in each day, and that could have been that is somebody that was licensed or working towards license to do the consultation, because the inpatient consultation, again, to have somebody actually each day make that a priority for them to go in and or do these consultations. Let me give you a number so you know what we're managing. So we have the inpatient service line the outpatient service line, but then we have this inpatient, and we're doing over 1,000+ visits a year with a very small staff. There's 4 clinical plus myself trying to also manage all this inpatient. But when I changed this model to having somebody responsible to do the inpatient consultation every day, that seemed to help not only for the staff in terms of making it a priority in their day, but just it took some relief off for the staff so that they could focus on their outpatient work. Again, we were using people that were working towards license as an alcohol and drug counselor, mostly because these are not billable services. So I was trying to be efficient, helping people get their supervision, get their experience, but also, and I can't bill for them. So this was a good, a good fit or niche. However, with over time, we realized that that service, even though I changed the model to have somebody specifically each day managing that inpatient consultation, that the staff, we didn't have the right staff people, and we were fortunate enough to hire somebody who has some lived experience. And I can't tell you the amount of positive feedback. And I think, Carol, you spoke to this, not only have we started to shift some of that culture in the ED a little more towards this person's coming back, but it's kind of instilling some hope. We've been able to engage those patients also for the patient's end. We've been able to engage them, keep them engaged, and kind of move them a little bit more to some outpatient resources or even inpatient. So that's, there's been such a positive benefit of having somebody with that lived experience doing that inpatient work. I think instead of having somebody from licensed, going in and not being able to kind of speak to what's it like to be in that bed, and how do you begin that conversation that, I'm being asked to be seen by a doctor. I think that person with lived experience just can bring in a different conversation at the bedside. I think that's been a big positive shift for us in terms of engaging those folks that have really struggled over the years. And the challenges, though, I think what Carol spoke to for us has been that hiring piece. Finding that person with that lived experience. I think Concord has, the area has been a little bit later to come to having an agency, a recovery-oriented agency. So I think that, that was a piece of it, but it's just, finding somebody that has that lived experience that's willing to do this kind of type of work has been a challenge. I can't think of any other things to say about it, but again, I think having the right staff, we have a good model. I believe our model is really good about how we're managing the inpatient consultation, and having the right person doing that work has really shifted the work in a really positive way. I think, also I would say that the other was us really getting embedded with care management. So we're starting, working with those folks who manage the bedside care, who are overseeing to make sure the bedside care is being coordinated, especially around discharge planning, and me being very intentional about making sure that we're massaging that relationship constantly, and they seeing us as an expert
Mhm.
and you know, wanting to at times just, you know, reach out and having more conversations with them who are seeing folks that they know that they need, that they need our support. So getting more referrals too from the inpatient.
Thank you, Monica. Oh, I'm unmuted for once. Any questions for Monica? A little different kind of arrangement than Carol described, but you know, I'll have to say from my own experience, it was just very obvious that the way that your folks feel like they are part of the team, and that was very, very obvious. And just am so impressed by how your team, which I've seen function on a few occasions, really is such a strong team, and the mutual support there for every member of the team, and that somebody who's a peer support worker is going to have that same experience with Concord.
Yeah, it's been a great win-win situation for us.
Okay, any questions for Monica? If there are none, I'm delighted. Cheri, welcome. Oh, go ahead, Lindy.
Yeah, I'm always going more into the weeds here. So you have this one person and this is their primary job, but their job is based on when you get referrals from places. So how is their time organized? You know, what do they do when they're not consulting?
Well, every day there's probably about 10, you know, or 8 to 10 consults. We're actually expanded our consultation service to Monday through Saturday, because we also have to support. There are some requirements for like a trauma certification. So anybody that comes in that screens positive has to be seen by us. So all their role is only inpatient consultation. That's it. So all the other outpatient, the licensed folks are managing. So they're just managing the inpatient consultation.
I have a question as well, again. So
Yeah.
when the consultation bit is assessment and connecting to services, like what are some of the details around what the consultation?
Sure. Sure. So so the inpatient consultation, just so that is triggered by, at this point in time, a hospitalist saying, and then they put in an order. And then that's all through the electronic medical record. We keep it, there's in the electronic medical record, that consultation comes through. So every morning, Beau, who's assisted by Haley, they'll look at who is on the inpatient consultation list and prioritize that to see those folks. They'll work really closely with care management, which I said at the end there, to understand the case better, if you will, and what the specific need is. But it's anything from just starting to engage that person about having a conversation about their substance, because sometimes folks, as we all know, come in, they deny that they, you know, that their tox screen was positive, or, you know, or they minimize how much their substance is affecting their health. So it's anything from beginning that conversation to helping them get into inpatient somewhere. It's you know, answering going back to Lindy's question too about their time. You know, this person or Beau, I've really asked him to really, you know, collaborate very closely with all SUD resources, and specifically really work closely with the Doorway, our Concord Hospital, the Doorway, but also other substance use disorder agencies throughout the state. Because I think it's really important that we maintain those relationships in order for someone that's inpatient, if they need a higher level of care, like going inpatient, that we have that.
Are they connecting with Archways?
So we're connecting with Archways. We do refer to Archways, but so I think that's a player that still we're continuing to, engage. Yep.
Monica, this is Kelly at Warner Douglas. I have a question too. You had said that it requires a consult, so that means a hospitalist.
Yep.
Recognizing that there's a need and be.
Yep.
intentionally ordering that, and 10 consults a day sounds high. Was there a time when it was very low? And if so, how did you get their buy-in into increasing usage?
Well, I think it was very low before we went to a hospitalist, and I'm going to date myself. You know, when primary care would come in the first thing in the morning, just check in with their patient before we went to the hospitalist model, which is probably 10 plus years, maybe even more than that. So the consultation was low. It's grown over the years, and I think it's just, you know, for us to be out there, you know, we try to be at nursing meetings, at care management meetings. We're at the Yellow Pod morning meetings. So we try to be, I've really encouraged this consultation team to be very visible at all the different areas that we can in terms of.
It sounds like that visibility.
Staff, yeah.
Thank you.
Mm-hmm. And I would just say, if we kind of organize that work too, the inpatient consultation. So we have our own little dashboard. So I can take a look. I know how many people Beau or Kaylee saw, as well as what was the, what's the follow-up? What's the plan, the next step? So if somebody's sick here, I've got, you know, if we have to cover, or if we got more consultations, I can flex staff and they are in the know about, oh, this is where we left off with this patient. Versus having to go through the electronic medical record and read a bunch. They know, you know, we get it, we've got it, our little dashboard that's really specific, and this is what the next step is.
Obviously, unmuting is still a challenge. Anything else for Monica? If
Monica,
not,
yep.
good.
Of
Good,
course,
Nancy.
you know me, Pete.
I do.
just
That's
like
and I'm
you.
always happy you're here. You keep things going. You're the energizer.
So in terms of the electronic health record and access, you've got your own dashboard, but do the peers have access to the entire electronic health record?
Yes. Yeah, they have access to the electronic medical. Yes.
Okay.
Yeah, because they're staff, they are part of our staff. They're hired, yeah, as part of Concord Hospital staff.
Okay, for further questions, Cheri, welcome. It is great to have you here, and welcome to the community practice. Cheri Bryer comes to us from Dartmouth Hitchcock Hospital, and her title, which I think is kind of exciting, is that you are a peer support specialist, but you also describe yourself as an advocate. And that really kind of struck me, and I reacted very positively. Thank you for your work. Thank you for joining us today. And the floor is yours to talk about the Dartmouth experience and your experience and what you have to share with us today about your work.
Thank you. So I was trying to figure out what I wanted to say as I'm listening to people talk. And I think I want to kind of start from the beginning and explain who I am, where I came from, and how I became interested in doing this type of work. And have been working as a recovery coach here at Dartmouth Health since 2016. So I'm a person in long-term recovery. I struggled with substance use. It started in my late 20s. So I was a later person that started struggling with substances than a lot of the people that I work with. But I was a mom, and my substance use started because I had a lot of medical issues, and I was prescribed opiates and other medications for long periods of time over several years. So gradually things became unmanageable in my life, and I struggled from my late 20s till my early 40s, and I have a long history with substance use disorder and many of the negative consequences that come with that in people's lives. So in 2015, I was volunteering at our domestic violence center here in Lebanon, New Hampshire. And one of the workers there told me about this training that was coming up, and it was a recovery coach training, and they thought I would be a really good candidate to send, and that they would sponsor and scholarship me to go. Back then I didn't have my driver's license, so I had to work around how I was going to get there because it was about 35 minutes away. And unfortunately, I wish Courtney was on here today, but Courtney was actually the person that was willing to pick me up every morning and bring me to that class. And Recovery Coach Academy class is a week-long training, and once you finish that, you get a certificate as a recovery coach, and then you can work towards getting your like license certificate through the Drug and Alcohol Bureau, which is a certified recovery support worker. And when I was in that class, I realized this is my calling. This is where I belong, and this is probably why I lived through all the things that I did, including several very near death overdoses that I had. So after I took the training, I was trying to find where would I be able to do this kind of work? Where would I be able to help the people that need the help the most, and people like me, who was all alone and my struggle at the end and didn't have anybody like me to talk to. In fact, the first time I went for help, I was inpatient at Valley Regional Hospital in Claremont, and I honestly thought I was the only person on the planet that had a problem like mine. I remember asking the nurse, you know, do you ever have you ever had anybody else in the hospital like me? And I couldn't believe that there was other people like me out there. So what I've strived to be first and foremost is to be the person that I really needed the most when I was struggling. And I really wake up every morning and try to be that person for the people that I serve. So when I was trying to find my way and where would I go with this training? Like, what do you do with it? I went back to my addiction treatment program at Dartmouth, which I was in that program myself as a patient for a little over 12 years. I was one of the first participants in the program. I was one of the first ones in our first IOP that we ever had at the addiction treatment program. And I went back there to my counselor and I said, I really want to work here, and I really want to show you what this role can do for people. You need to figure it out. Get me in here. And I begged and begged and begged for months and months and months. And finally, they figured out we had a new program that had started within the addiction treatment program, and that was the Moms in Recovery program. And that started in 2013. And so my clinician and the clinical director in that program talked, and they decided that they would give it a try, and they would bring me in on a volunteer basis. At that time, the Moms program was only available 1 day a week. We had two groups on that day. We had the outpatient pregnancy group and a postpartum group. And we had the clinical director, a midwife, the addiction doctor, and another social worker, licensed social worker, and then myself was added into that. And from the very beginning, I was accepted. They treated me so well. They always went to bat for me. For a long time, Dartmouth did not want to hire me on as an employee because along with lived experience comes a background, and my background was shady. So they didn't trust in making me an actual full-time employee at first. So after I volunteered for about 6 months and got paid with gas cards every Wednesday, we wrote up a contract, and they were willing to pay me as a contracted employee. And then things just really took off for the Moms program, especially because that's where I was to begin with. And within the first couple of years that I was working in the Moms program, we were able to get a grant, and we hired some more clinicians. We hired a resource specialist, and we have a woman that runs our playtime group. So we have playtime group for the kids when their moms are in group therapy or individual therapy. We have full services there. So we have a food shelf, we have a donation closet. So people bring items or take items if they need to. We have a partnership with New Hampshire Legal Aid. So once a week, we have a lawyer that comes in and can help people with issues such as housing or their food stamp or Social Security benefits, things like that. And then on top of the moms program, we also have an integrated program in our OB department. And I started in the OB department probably about 6 months after I started at moms. So on Thursday afternoons, and Tuesday mornings now, we have a Purple Pod clinic. That's an integrated clinic for women with substance use disorder. And pretty soon we're going to add people that have mental health issues, not necessarily substance use related. So that's going to be a great service to give to those people. And we have two CHWs that work in the OB department, in our Purple Pod and in OB. We have a social worker now, and the midwife that I work with here at the hospital and at the moms program, and our residents. We have residents that work with us for a year at a time. So every year in July, we get a new round of residents, but it's a pretty amazing experience for them too. And after I was working here for a while, they decided to start a program in our ED department. And we had on-call recovery coaches at first, but now we have a full-time person in the emergency department. And we also have, we've had 2 full-time people, but one person moved on. So right now there's only one on our behavioral intervention team, and that's our inpatient service. So people that are in the hospital with endocarditis or blood infections, or other, issues that related to substance use, they have a recovery coach that can go and talk with those people inpatient and try to help them with resources and things that they can access after they're not in the hospital anymore. And I have to say that I've been really lucky with the team of people that I've worked with. They've been very accepting of me, and they've always made me feel important and equal. I haven't never felt different from everybody else. I feel like I'm just as much an equal part of our team as anybody else. We have a huddle twice a week for the moms program. So it's our whole team. We come together and we talk about patients, what we're going to do on that day, what's been going on all week. And then on Thursday mornings, we have a huddle with the Purple Pod team. So always included in that. I do write notes in my patient's charts. I also have access to my patient's charts, but I choose not to go and look in people's charts because I want to meet somebody right where they're at on the day that I see them. I don't want to have any preconceived thoughts or notions before I meet with them. And so if there's something that I have a question or I need to know or an update, I go to the provider and I ask them, what is it I need to know before I go and meet with this patient? Most oftentimes I'm the point of access, and our patients at moms that have left the program and want to come back, or they've relapsed, and I'll be the first person they text and contact when they want to come back and talk to their clinician, but they're kind of afraid. And I'll oftentimes meet them when they walk through the door, and I'll be with them when they go and meet with their clinician or with the doctor, and really just be there for support and speak up for them if there's things that they want to say and they're a little afraid to say them, I'll say them for them. I also am able to go and do a lot of extra supports outside of a hospital setting with our patients. So I attend DCYF or DCF meetings with people. I go to court hearings if they have DCYF or DCF involvement, or if they're, if they're having some sort of issue with their partner and they have to go for a restraining order or something like that. I can go to court with them and be there to support them through that. I oftentimes support a lot of our patients when they have to go and get their blood drawn, because that's a huge trigger for them. And a very hard thing to get people to do. And I'm always advocating for them with providers and things like that. I always tell my moms that, I love babies. I think they're so cute. And I'm so excited that I get to do this work, but really I'm here to be their support person. Like they're the person that I'm here for the most. And I make sure they know that. So I just feel really lucky. I think some of the challenges that I've come up against is I do a lot of extra stuff now outside of my role. And so because there's only one of me, it makes it hard to clone myself and be in a lot of different places. We were able to hire a recovery coach for our general addiction treatment program, and he went on to get his LADC, and now he's a LADC with us. So right now I'm filling in that role on our general side of our program. So I'm probably working with, I would say every week I'm in contact, whether I see somebody in person or I'm texting with people. I would say at least 50 people a week I'm talking to. And then I'm always in our groups. So I do the IOP group with our moms 3 times a week, and I'm in our outpatient groups as much as possible. So I'm always around, showing my face, talking about my story, really trying to make connections with people. And I know from my patients as well as my coworkers that a lot of the things that we're able to do now wouldn't have been as successful as they are if there wasn't a peer support role involved. It's a very important role. It's a role that has a different type of connection and relationships with patients. And I oftentimes have a lot of people ask me why I'm not going back to school. But if I went back to school, I wouldn't be able to do what I get to do. And I don't want to give that up. So I'm doing other things. I just got my CLC, so I'm going to be a trauma-informed lactation consultant and try to get more of our moms to breastfeed. I also teach recovery coach training. So once a year, at least, I do a recovery coach training in our area. Right now I'm working with a LADC who works in Southern New Hampshire, and we're writing an ethics training on ethical dilemmas that I've come across, and other people, my peers, that have come across in our work, because there's a lot of things that have happened that I don't think were thought about when a recovery coach training was written. So that's going to be exciting. We're hoping to roll that out in the fall. And I think the only other challenges that I face, I think, is just really getting providers to utilize my services, to contact me when there's somebody on the birthing pavilion that I might not be aware of, and to really use the role of the recovery coach, because it's so important. And I think the only other thing that I can think of that's a huge challenge right now is just not having somebody else in my role that I can go to and talk to, that's doing exactly what I'm doing. Like I'm the only one that's ever done this at our hospital and in these departments. And so there really isn't anybody else. So I find that can be kind of lonely sometimes, and don't always know what to do with things. So I've learned a lot along the way, a lot of things not to do, or better things I can do, but I'm really like just teaching myself. So it's a process, and it's a learning thing every day, I would say. And then lastly, I guess I would just say that, finally, after 4 years, when my first criminal charge was 20 years old, the legal team here at Dartmouth Health was willing to take the chance of hiring me on as a full-time employee. And I've been able to have benefits now and vacation time. For the first time in my life, I'm saving towards a retirement. And never thought I would live to be this age. So it's amazing. And I'm actually like, just like everybody else here now. I'm an employee who gets to be treated just like everybody else.
I have two reactions. One is wow, and two is thank you. That was just extraordinary, and thank you for sharing that story. Folks, any questions for Cheri or wanted to elaborate on anything?
I'll jump in. Cheri, that was super cool listening to you and hearing your story. Thanks for sharing that with us and putting it all out there. But also it's really interesting to hear some of the comparisons. And I would say, even though, you know, we're sort of, I'm Concord Hospital-Laconia and Franklin, and even though we have some well-established programs here, I can really relate to the whole, like, we're still sort of an oddball, and we still sort of we're like the round peg that doesn't fit in the square hole. And sometimes they just don't know what to do with us. And, you know, where do we even fall on the org chart and under who, and right. So I could really relate to that part. And I mean, we're still going to share, and we'll talk a little bit more about that, but I just really appreciated hearing some of those things from you. Thanks.
Yeah. Do you work with Erica? Is Erica somebody on your team?
Yeah.
Yeah. So I'm doing a thing with the state of New Hampshire with her right now, where we're facilitating a work group. She's amazing. I love your program, and I'm definitely going to come and take a tour sometime and learn more about you.
Cool. And I guess the other piece for me would be, I would love to come take a tour too. And it would be a little bit selfish because my daughter works at Dartmouth in the NICU. So I was thinking the whole time you were sharing, like, you must go see parents in the NICU, right? Okay, keep an eye out for Erin and tell her mom says hi.
I will definitely do that. When
She'll be horrified.
When we had a grant through NEPQUIN, I was leading like a support group for recovery coaches, for some of us doing the same work around the state. And then that grant ended and it kind of fell apart. But I would love to have some sort of like monthly or something support group where we just get together and talk about like what we're doing and what we need, and help each other out that way. So it'd be great to collaborate and do something like that.
I think that's an amazing idea, especially because I feel like, and I'm sure Pete will echo this, and Monica, I think those of us who do try to like reach out to each other once in a while, we all kind of struggle with, how are you billing this? How are you building this into your EMR? Like, I feel like we're all sort of feeling our way through the dark with some of that. And so that would be such a good idea to get together once in a while. I don't need another meeting, but that would be an important one to add.
Yeah, I would second that. I mean, the idea, you know, just being included or involved in the development of the doorways, and over the years, we're constantly learning from what other people are doing, right? Because we simply just don't know. And so if you've seen what did they used to say? If you've seen one FQHC, you've seen one FQHC. And that's the kind of the thing with the delivery of substance use treatment too. It's just they're all unique, you know. Hence what has been shared today, all three very different experiences. Yeah. So
yes. Any more comments for Cheri?
Yeah, Cheri, hi. I just wanted to ask a little bit more about the supervision and your reporting and your support system. That's really what it comes down to. And do you have, you've talked about how you're trying to figure it out on your own. Has that been a conversation that you've had with your staff about, because I think support is such an important part of all of this. Just would love to hear more of your thoughts on that.
So luckily, the relationships that have evolved with my colleagues are at a place where I can go in and I can say, like, this is really hard. I'm having a really hard time. I need some guidance. What should I do with this? So there's times when there's like really heavy things that are dumped on me, and they're not dumped on anyone else the way they're dumped on me. And so I really have had to learn to really advocate for myself, which is something I never have done in my life. But if I don't do it, then who's going to take care of me, So, and the other thing that I implemented, because one thing they've learned since then, and we do have patients that have gone on to do peer support roles, and they've let them stay in our program. But when I was going to do this, they told me I could not be a patient at the addiction treatment place anymore because it was too much of a conflict. So I had to find other support, and that was a really hard thing for me to do. And I didn't do it for the first few years. And then I had a very bad personal thing happen in my life, and I realized I think I need to have my own counselor, and I don't think that's a bad thing. So so I definitely have a person like that I can talk to, on top of working with wonderful clinicians and people that don't necessarily 100% get my role, but they're a huge support.
Okay, anything else? Thank you. That was terrific. And our final group is from Concord Hospital at Lakes, and we welcome Corey Gately, who is the Director of Substance Use Services for both the Hospital-Laconia and the Hospital at Franklin, and Stephen, and I'm going to say Crowley. Am I correct in the pronunciation?
You got it.
Stephen is a certified recovery support worker and works with Corey. So welcome to the Lakes team.
Thank you. So, all right. I'm hoping you can hear both of us. We're on the same screen. I'm sure you can. Steve's going to talk in his big voice. I always have a big voice. So let me give you a little bit of background to begin with. Some of you have heard our story before. So Concord Hospital-Laconia and Concord Hospital-Franklin, we have a medication-assisted treatment program that we started, gosh, I keep losing track of time, probably more than 8 years ago now. And when we started that program, we started in Franklin, and then we were in Guilford as well. So we have both locations right close to both hospitals. And it wasn't long after that we had a grant from, we didn't, Navigating Recovery had, or no, I guess we did, the hospital did, back when we were LRG Healthcare, had a grant from the foundation. And one of the things that we did with that grant was we started a 24/7 system of recovery coaches. And what we did was we opted to contract with Navigating Recovery of the Lakes region, which is our local RCO, Recovery Community Organization. And we started a system where they could get called into either hospital at any hour of the day, 7 days a week. And so that program was basically meant to call a coach in if someone had overdosed. So a couple of things that happened really early on for us were that we pretty quickly shifted gears and said, we should be calling the coach in for anyone who comes in with substance use disorder who's willing to see a coach, right? It didn't have to be an overdose. So we switched gears in that way. And then we pretty quickly learned too, probably within a year to a year and a half, that the coaches weren't quite being utilized the way we wanted them to be. So we developed a hospital-wide education. And we've used that education over the years quite a bit. It was pretty much a 50-minute session. We kept it really tight. We offered it to the entire hospital. We had several departments throughout the hospital that made it mandatory for their staff to come. And it was the first time that we had kind of set out to educate the hospital about what we were doing. And so just in short form, what we did with that education was we talked about the briefest education about SUD 101, just so people would understand what we were dealing with. We talked about what recovery coaching is, what a recovery community center is and does. We talked about medication-assisted treatment, because those two pieces ended up being very linked, right? That the coaches would be coming in, but they would also be We were doing inductions at the time, beginning inductions probably about 7 years ago. And that was also something that we needed to share some education around and how to make referrals back out to the community after an induction. And so we rolled all that into one education. We offered it at the time, this was pre-COVID. It's funny how our world is either pre-COVID or now pre-COVID. We offered it at 20 separate times, so that we were trying to hit the late night shift, getting people very early in the morning. We had food that if you're trying to get people to education, just bring cookies. That helps a lot. So we offered cookies. We ran the education. It was Daisy Pierce, and she's the executive director of Navigating Recovery, our local RCO. So she and I partnered and ran this education together, and that made a huge difference. One fun little story we like to tell is that one of the local firefighters who didn't know that we had done this education came to us one day and said, something's changed in the ED. And we were like, well, what do you mean? What's changed? And he said, I don't know, last couple of times I've brought in like overdoses, like people's attitude is different. And we were like, hallelujah, like it worked. Because we had done a lot of work on anti-stigma and making sure that people understood that it was going to be much easier to make a referral to a recovery coach. We basically said to our staff, like, there's really harmful things you can say. One of them being, I always use this as my example because I heard it myself with my own ears in our ED. One of them being, why do you keep doing this to your children? And it's just not helpful. So what we did was we said to our staff, you have tools in your toolkit now. You can say things like, would you be willing to speak to a recovery coach? Or we have medication that's going to make you feel better, and we can help get you a referral to the place that's going to continue to work with you. Those are helpful things to say, right? And not stigmatizing at all. So that education helped a ton. And from there, our 24/7 system has sort of blossomed. And I was making a couple notes as the other speakers were going, just so I wouldn't repeat too much. But I thought I would touch on a couple of things that were hurdles for us and how we do things, just in case that's useful. Things like we are still subcontracted with Navigating Recovery. So all the coaches that work in our 24/7 system come from Navigating Recovery. They're subcontracted, but they've gone through our employee health system. So they're all badged. They all come in with a Concord Hospital badge on, and they have to abide by our policies and our rules. So when someone sees them, they see them with a Concord Hospital badge on. And so getting them through employee health, and in some cases having to really advocate with our hospital to make exceptions for things like criminal records. And we've been pretty successful with that, but they're all run through the same screening that the rest of us do to get into the hospital. And then the other thing was that we do have our own recovery coaches at this hospital too. I do have 2 CRSWs working in the recovery clinic, which is our medication assisted treatment program. And then we happen to be sitting in the doorway today. Here at the doorway, we also have our own CRSWs, but our contracted staff work both in our doorway and in our 24/7 system. So, and Steve happens to be one of those. And then I also wanted to say that our coaches coming in, because we had talked about this with one of the other presenters, don't have access yet to our health record. The way that works is it's still just a contracted service from Navigating. Eventually, here soon, because we've had so much change here, I'm sure you all know that from, it feels like we've only been part of Concord Hospital for a little period of time. In fact, it's been more than 2 years now. And we're still in the process of figuring things out. And so we have not gotten to the point where our subcontracted staff has access to our EHR, but we're getting there. So that's coming next. So I'm going to give Steve a chance to speak, but I'll probably do this more like an interview, if that's okay. And so I guess I'm hopeful that Steve will tell you a little bit about his story and how he got started here with us as a coach. How'd you get started?
Jeez, right into it.
I know.
So Originally, I'm from Massachusetts. My parents sent me up here to a rehab that was private pay in Laconia Hospital, or in Laconia. Wow, spend too much time here. And I did well in that program, and then ended up getting my own place. And shortly after, I had a pretty near-death overdose as well. Probably marking it up to number 12 or 13 in my life. And I was brought in here. I don't even know if it was still LRGH or the switch over to Concord Hospital yet, but I had the benefit of knowing about navigating recovery because some of the staff members also worked there. So obviously I agreed to them coming in, but that was like the first thing I was asked. And probably 2 weeks later, I had spent probably a week in a hotel, and I had a couple of those people from the rehab come and drag me out of the hotel, and they brought me up here to the doorway, and I sat with a gentleman who ended up being my recovery coach, and still, like, we were friends. We knew each other. He went through the rehab, so I knew of him. I knew what he did for work. I knew he worked up here. He ended up being my recovery coach at navigating after the doorway helped me get back into treatment and then sober living. And then, he advocated for me at navigating to get me in as a volunteer. And once I hit my 1 year, because we only hire full-time employees once they hit 1 year sobriety, he advocated for me to be the next male coach, to come on the team. And within that, I started working up here. I really enjoyed being up here. The staff that is up here every single day, they also had their own side jobs in the hospital as a patient safety attendant. So I jumped onto that and, worked crazy hours. But eventually I got tired of just sitting in the annex, which is the psychiatric hold unit down in our ER, watching video monitors and watching people sleep for 8 hours overnight. So I thought it was a great idea to go get my LNA. So I, utilized my PTO to do that. And as soon as I got that license, I transitioned from the float pool over to an ER tech. So I also work, here in the ER between Laconia and Franklin, as a tech. And to further that and open up more opportunities, I took my second year of PTO and went and did the EMT program at LRCC. Unfortunately, I've been unsuccessful my last 2 attempts at taking the National Registry exam.
You'll get there.
But working on it. But seeing the difference in the ER, like from when I first started doing the on-call program at navigating and coming in and meeting with individuals and providers being like, we can get someone into respite, or we could do this. We just have this barrier. So if you could potentially send them with a bridge script for this, or, if the individual was struggling with alcohol and we could get them into a respite, they're just asking for a taper of lithium or, whatever to kind of help alleviate any withdrawal symptoms, and providers were kind of hesitant on providing that. And then I walked in, one night and I was like, it could really benefit from this. And tell me what you need, and I just gave them a list of meds that was asked if they do come, that they would be required to be on for the time being. And the provider filled all those meds, sent them with them and everything. But it's also been beneficial to you know, we have a lot of travelers that are coming from all over. Not everyone knows about the on-call program. Not everyone knows what we do at navigating. You know, so obviously I work nights, night crew's the best crew. And, you know, to be able to sit down and kind of educate them, like, you know, on another level of, you know, expressing my thoughts, opinions, stuff like that, and providing my own lived experience on, you know, oh, this person is going through this or dealing with this because of this, you know, has definitely been beneficial to the point, like sometimes, like, you know, I've made my own family at navigating, my own family at the doorway, my own family on the softball field, my own family now in the ER, you know, so like I get random messages sometimes like, hey, we're dealing with this, any suggestions, you know, so.
I would say that our staff in our emergency department has come like full circle. And it's true, there's a lot of travelers and we have a lot of education that we need to sort of redo. But I would say there's times where I'm so proud of the system because our staff are really seeking out our coaches. Like, what should we do next? What did the coach say? Right. And we even have kind of one cool story mostly about Steve because he, you know, has a couple different hats that he wears now. And so he was working in the emergency department with his LNA badge on, right, and working as an LNA, and someone came in with having had an overdose, and the doc was the first one who came and got Steve and said, we need you, like, we need you to come in and talk to this person. And well, we as his supervisors had to process, when you have your LNA badge on, you're there as an LNA. At the same time, we were like, hallelujah. Like, we have doctors in our ER that are like literally know that the next step is to get the coach in there and get working on this. So that's been a really cool piece for us, is to see our docs doing that. One of the advantages we have too is having a champion in our emergency department. One of our ER directors is one of our providers in our medication assisted treatment program. So she is really in both places, and it's been super nice to have her, you know, advocate for substance use services when she's in the emergency department and really wanting people educated. And just to give you some idea, I think as far as our calls are concerned, I think that we probably average, and we're kind of rural compared to some of you, we probably average somewhere between 3 and 5 calls on the off shift daily. You know, this week is a little different because we're, you know, in motorcycle week up here. Yeah, it's nutso. And more nutso. I've lived here a long time. This is a super nutty week. If any of you are planning to come to motorcycle week, yeah, don't. Yeah, yikes. I mean, it's cool, the 100th anniversary, but wow, is it busy here. Just everywhere. Like I don't want to go to the grocery store. And so it's really been a great evolution as far as our system is concerned, because we're seeing our coaches called a lot more. We're seeing them relied on a lot more. It's just been a good experience. So did you want to add anything else about it? I think we covered a lot.
Yeah, I think we got it. I mean, the individual that the doc asked me to see, so it turned out I was gonna get him into detox, and his wife was there. She was all on board. He was on board, and then I don't know what flipped, but 5 minutes later, he was all set. He wasn't doing it. The wife was crying, looking to me. We also provide at navigating family support. So we have one of our coaches who, you know, she specifies, what's the word?
Specializes
more on, like, you know, the family support on, you know, wives or sisters or whatever of someone struggling. So I gave her our card, and she not only started seeing a coach for herself, but he also ended up coming and seeing me for quite some time, and doing very well. And I haven't heard from him for probably a month now, but he was coming for a good like 6 months on a weekly basis, taking, you know, his lunch break and everything to come meet with me. It's like, I don't remember anything. I don't remember how I got your card or anything like that, but my wife highly suggested I come meet with you, so here we are.
Yeah, and the only thing I think I would add to all of this is, I've worked here at this hospital. I don't really like to say how much time it is because wow, I feel aged by that, but I think I've been here for 23 years. So I started in the Nathan Brody program, which some people may be familiar with. And as part of being in that program, we used to send our counselors into the hospital to see patients. That we were doing that job as clinicians. And I have said for a long time that we were missing this piece because people don't always want to see me getting my foot in the door, right? That are ready to see the counselor come through the door, the therapist, whatever. It didn't seem to matter what word I used. It was not going to be well received. And I think we've just done such a service to the continuum of care to get people started by seeing a coach first. And I have had so many more people end up in counseling as a result of seeing the coach first, right? And spending whatever amount of time it is being connected to those coaches before they land in therapy eventually. And I just think that makes natural sense that we let someone process as much as they need to on that level before they say, I probably should dig into this trauma or some of this other stuff that I have going on. And so that's been really cool for me to see is how much better we do at connecting to someone initially by using our coaches. It's been a really good system. So happy to answer any questions.
I just want to say, just to like talk on that piece, what you ended with, in our OB clinic, oftentimes when we have a new person, a new OB visit, I'll be the first one to go in the room. And like, I mean, being somebody with lived experience, I can immediately be like, okay, so how much did you use today? You look, and we're really able to get somebody into the hospital, inpatient and inducted on methadone or buprenorphine, whichever they choose, and help them get into an outpatient program like immediately that day if they're ready to, if they're willing. But like without that piece, without me being able to go in and say like, hey, I can see you're struggling, I don't think we would be as successful, because I honestly, when I wasn't the first one meeting them, we weren't getting those results like we do now, because they weren't going to tell the provider that they were struggling. So that's great.
Yeah, same experience when we send our coaches in here at the hospital or at the recovery clinic. It's just a different mindset right from the get-go, which is good.
Other comments, questions?
Corey, I have one. So
I knew you would, Pete.
You knew, I know you knew. When you say you're on the way to getting the POIs access to the EMR, what do you expect to be the hurdles, or what are you sort of trying to solve?
So we've been trying to solve getting the right codes. Monica and I were both, oh my God, because we're in the same system, right? So we've been trying to get the right codes in for billing purposes for our coaches. And for me on this end, part of the problem is that they're subcontracted to the hospital. So I've had a little bit of, so I could probably have them all have access to our system now, but because we're not up and running with the right codes yet, there's really no need. So that's probably going to be less of a hurdle than making sure that we have all the right codes and the right ability to document. And again, that's where we feel a little bit like, I guess if I'm just going to be totally frank with a group like this, like I think most of us probably feel this way. We're a bit like the black sheep, right? And it's unfortunate, but like this is not normal hospital codes, and nobody really knows how to manage that financially for us. And some of what we do is just challenges our IT and our financial people in ways that they haven't been challenged before as a hospital.
Well, and none of the coding specialists have this as a specialty. right? I mean,
Right.
they're like, what? I don't know. We were very fortunate to have a person that was super, they had a lot of expertise, like in just billing, behavioral health, and substance use just in general. So, but there aren't a lot of specialists. And then you get to the denial bit, and no one really knows how to sort of qualify the denial. They're like, yeah, it's just denied. And you're like, can you help me with that? You know, a little bit. So, well, good luck with that.
Right. And the piece too, where if the claim is denied, I've been advocating very much that I don't want our clients to then get a bill, right? So because that just cuts people off even more at the knees, right? Like, I'm never going to ask for help again. I got a bill. So we've been trying to work on what we do with that. Like, how do we make a queue of people? And so that's been another hurdle for us here. But yeah, it's a lot, especially because we're still integrating our EMRs in general, right? So yeah, there's a lot of pieces that are just still kind of confusing about that.
So I'm just going to throw out a couple of things. I'm hearing this and it sounds like it's a common problem. Carol's sitting in the background nodding her head as well. This may be something that through this kind of coordination we're doing with the Foundation for Healthy Communities, that there may be a way for the hospital. I'm speaking now, I'm saying maybe because I have no authority around this, but for the hospital association to pull together a group of some of you with some of the kind of coding experts out there to try to resolve some of these kinds of issues. Because what we're hearing very clearly is that the service is worthwhile. And we've seen for ourselves in this meeting, and certainly heard in other places, that the people who are doing it deserve to be paid for it. And hospitals are not in a place where they're going to provide a whole lot of things they can't bill for. So, you know, it's a shared concern that there should be at least a way to make some progress with this. So I'm thinking that's something that, you know, Dan can take back to his crew and see if this is something that might be able to be pulled together by them. The second thing that I'm hearing across the board has to do with the camaraderie, support, and supervision. And we don't have time to get into it right now, but how these coaches are supervised and by whom, and whether there is the supervision by CRSWs for CRSWs instead of individual clinical supervision around this. And I'm sure that's working well in some places and maybe challenging in others. But even where it's working fine, it's also sounding like it might be useful if maybe even like quarterly there was a way to coordinate and let peer support workers that are in hospitals get together for an hour or two to just support each other and share issues and challenges and successes and that kind of thing, because I think that's just so important. And even if you have good support within your system, it's kind of nice to connect with people in other systems. I mean, I heard Cheri say something about that with Steve already, you know, just in this very short time that we had together. So I'm not saying this is something that has to happen, but I'm just throwing it out there for those of you who are doing it, and for us to actually reach out to other hospitals that are doing similar work and say, is there a need for something like this? And do we have a way of pulling it together so it doesn't fall on the individual hospital, somebody to say, oh, I'll do this for everybody. Maybe we can do it beyond that. So I'm throwing those things out, and I'd love to hear your comments back, but I absolutely have to leave because I'm in charge of picking up my grandson from school in 10 minutes.
So, Lindy, we shall excuse you for that duty, and thank you for joining and all the energy and your support of this work.
I'll just say that I love that suggestion. If you have to go, Lindy, that's fine, but I love that suggestion. It reminds me of the community of practice that we had for medication-assisted treatment when people were first sort of getting going with that. And that was super useful so useful to get together with all these other agencies to say, how are you drug screening? How are you managing everything, right? It was just so useful. So I can see how that would be both of those suggestions. I can see how those would both be very useful.
I agree. And community health workers, like they have a community health worker conference every year. They just had one the other day, and somebody, won an award for the community health worker of the, in the state of the year or whatever. And, just to even have like once a year, like conference or something where we got together and we could have different topics and talk about different things and get to know what other people are doing and learn from each other. I think that's so important. And we don't have that for this role. And I think there should be some recognition, and we should get some a chance to get together and meet, even if it was just once a year, like throughout the state. What are people doing everywhere? How are you doing it all?
Yeah.
So Dan, grab all these ideas and we will talk about this.
Yes, Lindy and I are getting together on Monday, and I'm also watching Nancy's body language, and that's largely a survival tactic for me, but I'm noticing her nodding her head. So I know that we will be having a Teams chat shortly after this meeting ends. Thank you. Go ahead.
Can I just say, Cheri, I'm on the NAHATICA board, so I'm going to bring your idea of a CHW type conference, peer support conference, to them, see if they're interested in doing something about it. I think that's a great idea.
Mm-hmm.
Thank you. That would be great. I know so many other peer supports people that would just really appreciate that so much. And we deserve to have some recognition. We do hard work out here.
You do. Lots of good ideas. Boy, I wasn't looking for more work when I started this COP, but I got some now, and I'm delighted. Thank you all. This has been such an amazing and just a great time together, and so much energy. With that, we are within 6 minutes of closing. We never go over. So if I may do so, Stephen is at the ready to kind of roll out our closing slides. But I just want to thank everyone for your attendance and for all of the absolutely robust dialogue we've had here today. And I'm sure there will be more. I'm sure that we'll be following this up. I know that the conversation follows with Nancy and one with Lindy. I want to speak to our partners in this work. You see Stephen on screen today. There is a team of at least 3 of them who provide incredible support to this. Oh, that's good to know. Okay, we got a note from Peter Fifield. Excuse me a moment as I take a tangent, but SOS has a peer recovery conference every year. Our technical assistance partners, growth partners, runs a number of communities of practice and covering prevention and other areas of the substance use spectrum. I invite you to take a look at them. I have joined a couple of those myself. They do a tremendous job in supporting this work, not only in the delivery of these, but also in compiling technical resources, in archiving all of these recordings and PowerPoints. Cheri, thank you. Great to see you today. And I would encourage you to visit their website at nhtac.org. I've had problems getting on that website, so if you just type in New Hampshire Technical Assistance Center, I don't know what it is, that'll take you right to where you need to be. And that's where the recording for this session will be in not too much longer. Stephen, what's my next slide? Oh, we have a survey. So there's an evaluation link there. You know how this works. You either do it now or download it, or I will be sending this out to participants if it works for you to do this a little later on. But we do very much appreciate your input and your thoughts about the work we are doing. We are now at the end of a program year, and we are beginning to ramp up to develop some content. Fortunately, we have at least 3 or maybe 4 of the people who are on the planning team here at this meeting, but we very much appreciate that this is a community practice driven by the participants. Stephen, I think that's the end of my script. If there are no further comments before we close the meeting, I will simply say thank you all and look forward to August when we have our next meeting.
Thank you, Dan, for all you do.
Thanks, folks.